Good morning. Good afternoon. My name is Nate Laxman. I'm a partner with Foley and Lardner, and I head our telemedicine and telehealth practices. We'd like to welcome you this afternoon to our Telehealth Data Privacy and Security Strategies and Solutions for Providers webinar. New technologies create new opportunities. In our firm, we are particularly engaged in the telehealth and telemedicine space, and we can see as a reflection of that through trade press and even mainstream media, it is an area of particular attention and focus among healthcare providers and institutions across the spectrum of care. And what we're seeing are a lot of questions, and today part of the intent is to have an educational program wherein we can get some practical discussions of the real-world application of privacy and security rules as they relate to services provided via telehealth. And to that end, we have an excellent panel of 3 speakers, and I would like to introduce them to you before we hand over the session. First of all, as myself, I'm just going to moderate, so you won't have to hear too much of me. We'll also hear from Dr. Brandon Welch. He's an assistant professor at the Medical University of South Carolina Center for Biomedical Informatics. His primary research relates to the development of health IT applications for genetics and family health history. Dr. Welch is the founder of DrMe, a simple, free, and secure telemedicine solution. He also leads the Telehealth Research and Innovation Program at MUSC, where he helps researchers develop and utilize telemedicine approaches in research. He is currently developing an online social network called itrunsinmyfamily.com for families to share health information. Before MUSC, Dr. Welch worked at the U.S. Department of Health and Human Services on the Personalized Healthcare Initiative and was vice president of Informed DNA, a nationwide telegenetics company. Our second speaker is Michael Carter, the Enterprise Manager for Media and Telemedicine Systems at Partners Healthcare in Boston, Massachusetts. With more than a decade of experience in media technologies and information systems, Mr. Carter has been instrumental in launching strategic telemedicine programs and virtual care services connecting patients and clinicians all over the world. These programs have been in partnership with hospitals such as Brigham and Women's and Massachusetts General Hospital. Additionally, Mr. Carter has worked closely with the Partners Center for Connected Health, playing a critical role in developing video conferencing solutions for their connected care programs. Mike received his bachelor's in science at the University of Massachusetts and is currently pursuing his MBA from Southern New Hampshire University. And rounding out our speaker panelists is my colleague, Leanne Hobte, Senior Counsel at Foley and Lardner. A certified information privacy professional, Ms. Hobte has legal and practical experience in data privacy and security, having advised telehealth and digital health companies, medical device companies, hospitals, physician groups, and a broad array of clients on matters such as compliance with federal and state health privacy and data security laws. She structures business arrangements and business associate relationships, develops privacy and security protocols, and breach investigation and reporting. A couple housekeeping tips before we kick it off. Today's program will run for 60 minutes. We will apply for 1 general CLE credit for today's program. So for those of you interested in the CLE credit, keep your ears open and listen carefully because I will drop that code at some point in time during this webinar. All New York and New Jersey and Kansas attendees must fill out an attorney affirmation form, which can be found in the resource list widget. Finally, we have several hundred registrants, and we certainly want to answer as many questions as possible. So if you have a question, please don't necessarily wait to the end. You can submit it through the broadcast by clicking on the Q&A tab at the bottom of your screen. We will endeavor to answer as many questions as we can. If for some reason we don't get to yours, I'm sure the speakers will be happy to follow up and reach out. Similarly, at the end of the slides is the contact information for all 4 speakers. Do not hesitate to reach out because they all sort of share the same vision about wanting to promote and educate everyone to utilize telehealth and telemedicine in their practice. So at this time, I'd like to hand over the microphone to Leanne Hobte.
Thank you, Nate. So I'm going to begin this webinar by discussing some of the privacy and security considerations that are generally unique to telehealth. So when we talk about telehealth, we're basically talking about 3 types of delivery methods. The first, and what we most commonly think of, are the virtual visits or the telemedicine consultations, be they between a patient and physician or between a specialist and a physician who are consulting? Well, initially such consultations took place via video conference. The trend is currently toward providing services using mobile devices such as smartphones, laptops, and tablets for virtual doctor visits. Secondly, there is the category of remote patient monitoring, where a medical device is actively monitoring a patient in, for example, a home setting, and transmitting the results to a physician electronically. And lastly, there is what we refer to as store and forward delivery methods, where images are stored and forwarded to a specialist for later review. This type of technology delivery is typically used in specialties such as radiology, dermatology, and pathology. We're focused mostly today, I think, on the virtual visits, but when we think about telehealth, there are certain unique privacy and security risks that must be taken into account. Mike and Brandon are going to talk later about specific approaches to addressing these risks, so I just want to highlight them here in the beginning of our discussion. So first, there's the issue of the security of the transmission itself, which is taking place over communication lines or via the Internet, and creates a risk of possible interception. A second area of risk has to do with the number of platforms and entities that may be involved at some point in the provision of telehealth services. So we see in telehealth a greater number of platforms involved, including for the transmission of data for data storage. This increases correspondingly the risk of breaches and the difficulties associated with attributing responsibility for any incidents that do arise. In addition, as both physicians and patients are using mobile devices to engage in these visits, there are the vulnerabilities associated with viruses or lack of security on devices over which a telehealth provider has no control. Thirdly, there are considerations associated with data management, including both the storage and maintenance of large volumes of data that are generated and recorded from telehealth encounters, including images and video recordings. In such encounters, not only is there less control over the nature of the information collected, but there are practical considerations associated with arranging for secure data storage and retrieval. And lastly, there are the physical safety issues related to the privacy of the consultation. So here in a telemedicine environment, we have physicians and patients interacting where a patient or sometimes a physician may be in a home setting. These are not controlled environments, and there's a possibility for loss of control of the data or for a variety of incidental disclosures. With respect to the legal framework, I just want to touch on that there are multiple laws that may apply at the federal level. There's the Health Insurance Portability and Accountability Act, which most generally applies. There are also discussions taking place about the Federal Trade Commission and Federal Communications Commission roles in regulating telehealth over the past years. The FTC has the authority to regulate business associates and other healthcare providers under its Section 5 authority for unfair and deceptive trade practices. The FCC has the authority to regulate the communications infrastructure. The FDA has the authority to regulate medical devices, which would include active patient monitoring devices. And of course, there are the state laws that govern consent for telehealth services, as well as the use and disclosure of sensitive information, and in some cases, information security and data breach reporting, which must be considered by any company that operates nationally. When we consider HIPAA implications for telehealth and compliance, there's first of all the question of whether the telehealth company is a covered entity, a business associate, both or neither. Clearly, if a covered entity is providing the services within their own system, which could be a covered entity or maybe a affiliated covered entity that operates as a single entity, then it will need to be in compliance with its general requirements as a covered entity in the performance of such services. There may be cases when that covered entity provides services for other entities, and then it takes a business associate role. But I think most commonly what we see is that the telehealth platforms or companies are business associates under the HIPAA rule. And that is because the business associate is defined as an entity that provides certain financial or administrative services, including data transfer services. So business associates will be directly, such as telehealth platforms or companies, will be directly subject to HIPAA and must comply with the requirements of the security rule, the breach notification rule, and certain privacy requirements related to the minimum necessary standard and mitigation. In addition, there may be certain contractual obligations that are introduced through the agreement with the covered entity. There are a few cases where entity engaged in telehealth services may be neither. For example, if there is a monitoring device company that provides services on its own behalf and transmits information to a healthcare provider for treatment purposes only, they may consider themselves to not be a business associate. This is an area where there's some ambiguity. Covered entities generally like to take a belt and suspenders approach and require any entity with whom it is not clear to engage in a business associate arrangement. So, but moving on, and determining the kind of nature of contractual protections that must go in with respect to privacy and security, one of the big issues is the role of the telehealth company and the range of activities it's conducting. Another key issue with regards to data management is the chain of custody of information when providing services. There may be multiple business associate agreements and sub-BAAs involved, and it's really important to understand the relative responsibilities of the parties and the attribution of liability in such arrangements. And a further consideration is that where entities interact directly with consumers, there are cases where they may obtain from consumers the authorization to use their data for certain purposes. All of the issues related to the privacy of handling consumer data, including and patient data, including resale, data mining, marketing purposes, and use of de-identification or de-identified data are important considerations in working with a telehealth provider. From a security perspective, key issues include, encryption, authorization, authentication, the nature of data storage, and many more. So I'm going to switch gears and describe some practical compliance considerations. So first of all, a notice of privacy practices must be provided when a patient engages with a telehealth provider. The notice of privacy practices must be that of the physician or healthcare provider who provides the services. It could be provided by the vendor, by the provider themselves, by a management service organization, on behalf of a friendly PC or in other ways, but that is certainly a consideration. And acknowledgement must also be obtained. In addition, telehealth providers should have a website privacy practice notice that describes how they collect and use any consumer information related to the site, if an account is used for billing purposes, etc. These are different than the notice of privacy practices because they are not necessarily for or on behalf of the specific provider. The terms of use of telemedicine services should also be provided and agreed to, of course, by the patient, and such terms generally address issues such as setting up a subscriber account, agreement to receive communications via email, electronic signatures, user responsibilities with respect to use of the site, and any disclaimers with respect to the telehealth platform's role in the provision of medical device. And lastly and importantly, there's also consent requirements. About a third of state laws include specific requirements for consent to telemedicine services. Some state laws outline the specific requirements of such consent. Some require consent in writing. Some require consent when using emails and text messages. And in some states, informed consent is required. So all the elements of informed consent must be included in such forms. So we generally recommend that companies that provide telemedicine services across multiple states develop a consent form or an informed consent form that complies with the most stringent standards. In a web-based environment, it is acceptable to deliver these notices via pop-ups. The privacy rule, the HIPAA privacy rule, allows HIPAA authorizations to be obtained electronically from individuals, provided any electronic signature is valid under applicable state and federal law. That means it must be consistent with the requirements of the federal e-sign laws, and which require conspicuous notice of the contract terms, assent, generally by a click-through on an I agree or I accept, authentication of the individual, and certainly maintaining copies of the consent forms. Other issues to consider in state laws is which law applies with regards to interstate consults, and I think the answer to that depends. With regards to laws that govern the use and disclosure of medical information, for example, or informed consent, the laws typically apply to a provider of healthcare services or a healthcare practitioner. That means that disclosures, including authorization for disclosures for payment, should be obtained within the context of state law. On the other hand, when it comes to breach reporting, the scenario is slightly different. And in some cases, state laws that require notification of breaches of personal information apply to entities that conduct business in that state and residents of that state, whereas in other states, such as Texas, for example, an entity that does business in that state must notify residents of all states, either according to Texas law or the law of that state. So the laws on that issue vary considerably, and state breach notification laws generally have a shorter time frame for reporting for notification and may have additional requirements, such as notification of the Attorney General. With regards to ownership of the medical record, generally, according to a recent report, the provider owns the medical record, or state law is silent. There are a few cases, such as in New Hampshire, where the patient owns the medical record if the record is a record of a licensed health facility. I mention this only because state laws must be considered in contractual agreements that involve ownership rights to such records. And lastly, there are the medical record requirements. So I often get questions about whether the video or audio recording is part of the medical record or subject to HIPAA requirements. And according to national guidance, the requirements are for the record of the video consult are the same as those as for medical records. Further, specific telemedical records associated with the encounter should be created that include information on the visit, the history, review of systems, consultative notes, or any information used to make a decision about the patient. Also, it's important to note that patient registration information needs to be obtained in addition to informed consent, and retention of medical records must be in accordance with state law and other privacy regulations. So going through my last slide, I'll try to move through quickly, but I just want to mention that if you're providing telehealth services across national boundaries, there will be additional considerations. For example, if we look at the EU, Directive 9546 EC is the general law on the protection of personal data. Data protection rules apply not only when the data controller is within the EU, but whenever the data controller uses equipment situated within the EU. So to the extent that services are being provided in the EU, EU Data Directive would apply. There are additional requirements with regards to consent and safeguards. If data is transferred across a country border, it must comply with the specific requirements for data transfer outside the EU, including the safe harbor regulations for EU-US data transfers. And in addition, if data is stored in the certain jurisdictions, such as Italy, for example, there are extensive data privacy regulations that establish specific security protocols with respect to storing the data, authentication, backup copies, and a variety of other issues. So with that, I would like to conclude my section of the presentation and pass it on to Michael Parker. Mike, who will talk about, will give us some great guidance on setting up considerations with respect to a telemedicine system.
Thanks, Leanne. This is Nate. Before we hand it over to Mike, one follow-up question for you, and we're getting a lot of questions from the attendees, and we'll relay some of those at the tail end. But you spoke a lot about different state laws, international jurisdictions, on a variety of elements. I mean, are there ways that to have standardized processes so telehealth providers can roll out a scalable operations across all 50 states, or do they really need to do one-offs for all of their different documentation and processes?
I think what makes sense is to really look at the states where the laws are the most stringent and to develop a practice or protocol that complies with the laws of the most restrictive states. That way, the provider is covered for all states and does not have to get into the issues related to customization and the complexities associated with that.
Thank you. Mike Carter.
Thank you, Nathan. So as Nate mentioned, my name is Mike Carter. I'm the Enterprise Manager for Media and Telemedicine Systems at Partners Healthcare. And in general, I work with providers and programs to help them stand up their telehealth programs and assist them in supporting them after the fact. To get started, I'd like to just bring you through a conversation I would have with any provider within our network, and that is to set some context. So first things first, when I think of telehealth systems, I think of them as being IT systems because they're basically held to the same formula of success as any IT system. And that being, we're trying to solve a business problem or a business challenge, whether it be you're trying to alleviate some, or you're trying to add capacity within clinical area, you're trying to increase patient satisfaction, things of these natures. And you can't do that with just technology alone, which I'm not sure if our attendees have felt this way, but I often hear that people are just trying to throw technology at a problem and hoping it will resolve itself. But basically, you need two things, and that is both a process and technology working together to create a successful IT system. An example of sort of how this can go if you don't have both of these things in mind, we had a program at Partners when we were first starting out where we had a video conferencing technology and we thought that'd be enough to start a virtual visit program, and we quickly found out that without some of the scheduling processes and understanding culture and all these other things, the technology just could not live on its own. It really needed more on top of that to function. And I'm going to talk a little bit more about that later on in the presentation. But in my next slide, this is really some components of IT systems. And as you're starting to look at telehealth at your practices or your hospitals, chances are you're going to end up touching one of these areas. And it's important to identify early on which one of these areas you'll think you'll be working with, because in some cases you may be working with one area more than another. And then once you get to that point, you have to figure out how to deal with some of these mediating factors that come up, culture, environmental factors, structure, decision support, all these things. And just to touch on culture just real quick, because this is something that I come across every day as being one of our biggest challenges, and specifically with consumers. And there's IT term being thrown around now. Some of you may have heard of it being called consumerization. And what that is that's our users, our patients, our other doctors, people bringing their personal devices into the workplace or into our hospitals and looking to use them to either help manage their care or utilize or pay a bill or something of that nature. And it is a challenge with your technology to be able to keep up with the rate that consumer technology is going. So certainly something to keep in mind as you're choosing technology. Which brings us to our next topic. So when choosing technology, my assumption is you've gained buy-in from your main stakeholders and your staff, and you've found a clinical champion, someone who can help you drive this home within the practices. So then you end up asking yourselves some of these questions. First being agility versus sustainability. Typically when you are building a technology in-house within your IT department or another innovative group, you typically have a lot of agility. You can make changes very quickly. You can do things on the fly. It can be a very iterative process. But sometimes that's not as sustainable as one would like. Sustainability speaks to, I'm working with a company who's already gone through the paces, already been through the research, and specifically some of the security protocols that you need to stand up a telehealth technology, which we'll also touch on later on. So those are the types of questions you want to make sure you get a good handle on it. Which area do you really want to land in? You might also come across the situation where you have a internally developed solution within your organization. And that's come up often for me. And one of the ways I've addressed that is you need to bring it down to business terms. And you need to take an unbiased approach of comparing those technologies, using technology consultants if necessary to help figure out what is the right approach for you in your organization. And then you get to some of the larger questions. What is feasible? Sometimes, almost like when we're looking for a home, we want the best home we can get, but this is what we can afford, and this is what we can afford to maintain on an ongoing basis. So it's important to sort of identify those things early on. Also, think about what scale might look like. So how many users do you think you'll have on this system in 3 years versus 5 years versus next year? Do we need to buy the big Cadillac right away, or is that something we can do in sort of a phased approach? And then lastly, and this one is very important, is could this be an enterprise system? When you think of enterprise systems, we think of things like email, EHRs, these large systems that become mission critical, and they require extensive and robust support programs behind them to make sure that they can stay operational, sometimes usually 24/7. Which is a good segue into sort of the next slide, because often these enterprise systems have to have many integration points. And integration points are important for any technology. If you are building technology that may be outside of or mirror other technology that is in your organization, you'll often find that it may not be sustainable. But by having integration points, you gain a lot of different business pieces. So automation can bring efficiency, it can reduce cost, it can also increase capacity through these different integration points. And we're going to talk about what some of those are now. Important thing, and I see this a lot in some of the healthcare systems we work with, it's all about reducing the amount of disparate systems. Nobody in the culture wants to use 20 different applications to do their work in any given day. They want to work with one application that can sort of bring them to where they need to go. And so many of the integration points that we see in our telehealth systems now are things like single sign, being able to log in with the same username and password that you use for the rest of your organization. Also, Active Directory. Active Directory is a database that basically tracks when you are an employee and when you are not, and that's important. We're going to get back to that in a little bit. And also things such as EHR integration are also important, and it will tie you to sort of the mission-critical policy and strategy of your organization. So, and that's important to keeping your technology sustainable. So where to focus, right? We talked about the disparate system. We talked about the clinical system tie-in. Something else to think about as you're thinking about integration is if you're looking at cloud services, what does that mean to integration? Because there are certain integration points that are just they're a bigger lift or a larger effort to get going if you're using something in the cloud. So you want to make sure you understand what your points of integration are before you buy, so then when you start talking to companies, they can plan and develop and budget for it. Because if you don't, it's often the case that you end up paying for it later, and it's more than effort and cost than you anticipate. So hopping topics to sort of privacy and security overviews. So I'm going to read this one line because I think this is important and it summarizes sort of the challenge very well. And that is, our challenge as telehealth professionals is protect PHI as it moves through the healthcare system. I'm going to talk a little bit about the HIPAA guidelines in the next slide, but what I've done here is I've listed some potential obstacles, things we have to overcome as telehealth professionals to make sure that we are operating securely and privately. And I think any security professional will tell you nowadays that the biggest risk is not as much the hackers, the state-sponsored attacks, or the identity theft. It's typically the person sitting next to you. It's the patients. It's the people who just don't have any education around security and the different types of ways that people are trying to get their information. Unfortunately, we live in a world where not everybody has good intention. And I'm not sure how many of you have come across this, but I certainly can speak to it. I've received an email from bankofamerica.org saying that I have money waiting for me. Just click on this link, and it turns out that that's not a real website, and they're just trying to get my information, and they successfully would have done it if I had clicked on that link. And so the biggest thing you can do to combat sort of the security and privacy breaches within the technology is really education. And it's education of your own people, putting standards, putting ongoing trainings together so people are just educated around the different things that come into play when you're dealing with these types of attacks. So let's move on to the next slide, which is approaches to security. So it is a changing landscape. We don't live in the same landscape we lived in, I would say, even 10 years ago. I talked about state-sponsored attacks. I mean, we see some of those over the news even in the last year. So what do we need to do as far as technologists? And that is, we need to make sure that the HIPAA guideline is upheld. And that guideline, as I understand it, is keeping data at rest and data in motion encrypted from end to end. And there's lots of different types of encryption out there. There's encryptions of servers, typically called SSL encryption. There's encryption of data in motion, typically called AES, and then there's lots of different types of proprietary encryption. So it's important to understand when you're looking at technology, what are they using for encryption and where are they using it? Often in video technology specifically, if they're not careful, they'll find that the actual application is secure. It's secured by the SSL encryption, but the data is actually not. And they didn't take the extra step, which is to encrypt that data as it's moving through the internet. So very important to ask those types of questions. The other is sort of proving who you are. So two-factor authentication is lots of tech words just to explain that, and you probably have experienced this when you're logging into your banking portal, where they ask for a username, and then they're asking you to basically prove you are who you are by asking you a series of questions. It could be, what was your high school that you went to, and what is your mother's maiden name? Maybe it's, can you type in this image into the box, and so that you can move on to the next step and actually access the application. But what we're finding is that the single-factor authentication, just using a username and password, is just no longer the way to do things and keep your security in play. And then the last, data management, and Leanne talked a little bit about this. And so obviously data management is that PHI that's living in your server somewhere, and we want to make sure that is safely secured, both with hosting security but also with encryption. But it could also be something as simple as people coming and going within your organization and making sure they no longer have access to the systems. So I find in telehealth specifically, one of the hardest things to manage is people who are involved in your telehealth programs who are not part of your organization. So you have very little visibility into when they've actually left or have joined a new hospital that's involved in your program. So sometimes you just have to come up, the technology may not solve that for you, to be honest. You may have to come up with a manual process just to make sure that you're tracking that and that people don't have unauthorized access. Moving to the next slide, and this is sort of my scary slide at the end. Definitely security breaches are on the rise, and I think we're seeing this in healthcare, especially in the last few years. And I have a 2.5 billion exposed records since 2014. I have not even counted the recent breaches of this last year in this total here. And I think the other sort of scary part of this is that our technology security professionals, they're just not familiar with telehealth yet. So it's still an unfamiliar territory. So they're going to rely a lot on the clinicians and the specialists within their hospitals to help them put good standards and security policies in place. So how can you prevent these types of security breaches? Let's get down into that. So the first and foremost, and this is very important, especially when you're working with startups or companies are sort of in the beginning of their company's life cycle, and that is third-party code audits. We need to make sure another company has performed some sort of audit of that code to make sure that there's no flaws or back holes or any way they can get into that system and start wreaking havoc or pull information. The other is hosting security reporting. And so this is very important if you're working in the cloud or things of that nature. You want to make sure that the servers that are not owned by your organization are protected appropriately. And what I would typically ask for are SAE reports, specifically a SOC Type 2 report, and that will help sort of reassure you that you have what you need. And then thirdly, the active monitoring of the system. Often we have systems that are stood up, but there's not really any type of service put in place to make sure has it been hacked or is it down or is it up. And those types of things are really important to have, as far as policies and in your service agreements with your technology partners. And then last, standards of what to do once a breach has happened. Who do you contact? What are the next steps? Do we take down the system? Do we leave it up? Those types of things you want to make sure you have in place before you make technology decisions. I believe that is my last slide, and so I will hand it back over to Nate.
Thank you, Mike. I really appreciate the practical application of a lot of these concepts, how they are utilized in a hospital and health system context. Let's hand it over to Brandon to pick up the third part of our presentation.
Awesome. Thanks a lot, Nathan. So as Nathan mentioned at the beginning, I'm the founder of Doxy.me, and Doxy.me is a simple, free, and secure telemedicine solution. It's really a telemedicine platform that we developed, and so I'm talking from the perspective of an actual telemedicine system and the approaches we took to assure privacy and confidentiality and security of our users and patients. And so to understand our approach, I think it's good to understand where we came from. So I developed Doxy.me a couple years ago when I was at the University of Utah, and I was there working on a study where we wanted to provide remote care for pregnant women. And so mostly around reducing the number of in-person visits for prenatal care, because prenatal care is about 15 in-person prenatal visits, and if you've ever been pregnant or had a wife who was pregnant, you'll know that a lot of those visits are sometimes unnecessary. And so we could reduce the number of in-person visits by meeting with these patients by video or a telemedicine approach. And given my background, I was tasked with coming up and finding the solution to use. And initially I wanted to use Skype or FaceTime because it was simple, easy to to use, and patients were familiar with it, but our institution wouldn't allow it because they didn't feel it was HIPAA compliant, and they didn't sign business associates agreement. So looking at other solutions like Cisco and Polycom, the more traditional telemedicine solutions, it just wasn't practical for patients to use at home because it required hardware installations, it was expensive, difficult to use, and it just wasn't the best fit. And so being familiar with the technology, I set out and I developed DrMe, which is an entirely web-based system, and we rolled it out and used it in this prenatal care study. And so a little bit of little overview of how DrMe looks. So this is a screenshot of the dashboard. So essentially a doctor would have their DrMe account or their room, and you'll notice that they have their own room name. In this case, mine is doxy.me/Dr. Welch. And this is what a clinician would hand out to a patient and say, meet me here. And the patient would then use that URL, and that's how the patient would connect to me. So when she would join the room, the patient, she would appear in the queue up on the left in the waiting room, and I click on her name, and we start a telemedicine call. And it's pretty simple, and it's a way to facilitate real-time communication. And this slide is actually DrMe being used in this prenatal care study. So it's been used for over 2 years now in this prenatal study, and they just finished up the study. But throughout the study, other clinicians heard about it and wanted to use it, and so we made it available to the public last June, and essentially been making it for any doctor who wants to use it. But it spawned from a research study. So as I'm talking about the areas of privacy and security, I'm going to harken back to this experience and why it was set up as justification for why we took a couple of these approaches. First, we have 3 main areas that we focus on privacy and security within the platform. And the first is around real-time communication. So a little bit of a schematic of how a lot of these video platforms work, and this is actually how Skype and FaceTime work, is that they have what's called a media relay server, which sits between the 2 clients. And so on the left you have, say, the doctor, and on the right you have the patient, and you send a request to the server processes the request and connects you with the person you're trying to connect to. And all of the encryption keys, the certificates, the verification, everything is done on the server, and the server essentially connects person A to person B, and it flows through there. And so the data flows through these servers as well. And this is the approach of a lot of video solutions like Skype and FaceTime. The approach that we took is more of a peer-to-peer model, and we use a technology called WebRTC, which is a new standard that is backed by Google. It's open source, that uses a peer-to-peer connection. And so this real-time communication, what happens, one individual sends a request to the other individual, and that interaction and that verification and encryption happens on the other person, on the other client's computer, and then the response is sent back to the initial person, and that person also has the certificate and encryption take place there. And so it really cuts out that computer in the middle where a lot of this takes place. And it's a direct peer-to-peer connection. It's a little bit more complicated, but it gets around having somebody or something else between 2 individuals. And so we see this as a more secure way because in the media relay server, there's always a chance and always an opportunity that somebody or something could get that information or see that information that's outside the control of the client or the participant. I trust Skype and FaceTime that they're not going to do this, they're protected, but there's always that chance. Also, there's debate in the industry as to whether these companies need to sign a BAA. Because the data is flowing through these servers that are managed by Skype or FaceTime or something else, do they need to sign it? Now, if it was a telemedicine company that was using this approach and they signed a business associates agreement, then it should be covered. But there's always that chance that there could be something in there that could get it. In the peer-to-peer model, there's nothing in between that is accessing this data or seeing it. And even if somebody was able to capture a packet of information that's transferred between person A and person B, they don't have the encryption algorithm to decrypt the data, so they would see gibberish essentially. And so we see this as a more secure approach for the real-time communication piece. So the second area that we focused on was around patient confidentiality. And so everybody's familiar with the Ashley Madison hack, where this adultery website, hackers released the names of people who use the site. And essentially what this has shown us is that the people who are on the site are guilty of adultery by association with the site. Now, nobody was actually there to see that they committed adultery, but the fact that their name was on this, there's a higher likelihood that they did commit adultery at some point because they were users of this site. So moving forward and how this applies to healthcare, here's an example. This is I mocked this up, but it's, let's say you're out to eat in the community and you see your neighbor walk out of an HIV treatment clinic. And you don't see their health records, and you don't see their data or them actually getting the treatment, but the very fact that they're walking out of this clinic, you can kind of associate them with having HIV because they're walking out of an HIV treatment clinic. Now, they could be there for a family member or a friend or something, but there's that confidentiality aspect that is compromised by association. So people don't need records access to associate you with something like this. And so that is something that we paid attention to as we were doing this, is how do we protect the confidentiality of patients who are using our site? And maybe there is a doctor who provides behavioral health or mental health. Do we want them, and if somebody sees that they're meeting with this doctor, do we want them associated with that and in fact compromising their confidentiality? And so the approach that we've taken with Doxime is that we're an entirely browser-based solution. So we don't require any downloads to use. We don't require any login or registration. So patients, all they need to have a call is to have that URL, doxy.me/Dr. Welch for my room. And they access it through their browser. They didn't have to install any plugins. They didn't have to create a user account or a password or anything. To enter the room, they just type in their name and they check in. But all this information is essentially anonymous. We just collect the name for convenience for the waiting room queue for the doctor. But this information is not stored. We do keep meeting logs for HIPAA reasons, so you have to have a meeting history, but you'll notice in here we don't have any patient identifiers. We don't have IP address, we don't have their name, even the name that they enter, because it's that whole association, confidentiality, guilty by association thing that we're avoiding. And so essentially our users, our patients, are completely anonymous when they meet with doctors on this. So even if we did have the system hacked, or even if we did have a rogue employee who released all of our information, there's no patient information in there to begin with, so nobody could ever be associated with using Doxime because there's no record on our system of them ever using or having a Doxime call. And so that's one way that we protect our users to protect our confidentiality. And so an important aspect is that this does not compromise what we're trying to do. At the end of the day, what we're trying to do is make it easy for doctors and patients to connect and see each other by video. We really don't need users or patients to log in order to do that. So we don't do it, just to keep it simple and to reduce this chance of a confidentiality breach. Now, one of the questions that we get asked is, well, how do you know that the person who's the patient is really who they say they are? And our response is, well, do it the same way you do it in the clinic. When you go to the clinic, you don't make them create a username and log in and register when you go to an actual clinic. How do you do it? You have them show them your ID and license and insurance ID card. And with video, we have the ability to do that exactly. So what we tell our doctors when they have this question is just have them show them your ID and card, and that provides all the identification you need to prove that that really is that person you're talking to, and it's a heck of a lot easier than signing up for a registration and a login for these patients, and it's what's done every day in the clinic, and so we're going to use that same approach. And finally, the third thing around protecting our patients or our patients who are using the system is protecting their health information, and the approach that we take is we don't collect their protected health information, because how we view the world is that we as Doxme and telemedicine platforms are a communication and interaction platform. We're not a documentation platform. We see EHRs as the documentation platform, not as communication interaction platforms. And so we see EHRs having their purpose, and they're good at that, depending on who you talk to, but they're good at that, and they serve their purpose. And Doxme, as a telemedicine platform, we have our purpose, is to make it easy and more efficient and simple to communicate between a doctor and a patient. We're not going to bother collecting health information because that's not our purpose, and that's not what our focus is, and that's not our strength. And we get asked the question, well, does Doxme integrate with the EHR? And we say, we don't want Doxme to integrate with the EHR because they're two different systems, and well, how do they work together? And this is a simple workflow that we've actually have set up at the University of Utah that others have adopted, where they simply have a simple laptop, or in this case, this is a $200 Chromebook we bought from Amazon, and we set it up next to the computer that documents in the EHR. And what this allows the doctor to do is to see the patient with one computer, because that's the whole purpose, is to see the patient and to talk to them so they can see you, and on the other computer, the doctor can chart. And so this is actually the OB meeting with a patient. This patient happens to be my wife, who was in the study when we were pregnant with our second child, and charting on the other computer. And this workflow, it's so simple and easy, but it really complements the two strengths that these systems have. Doxme's strength is to communicate and interact and make it simple, and that's what's done on one computer. And the EHR, the health data interaction, is done on the other computer in an EHR. And this has worked out really well, and we see opportunity for them to integrate with scheduling, and that's simple, where you can put the room URL and send it to the patient. But as far as the workflow and usability and actual interaction with these two systems, they should really be separate because they have separate purposes and needs. And so that's the approach that we took now, and we're focused on meeting with patients at home. Obviously, there's different needs and workflows if you're meeting between two hospital systems, but this has worked well for us and our users, and that's how we're doing it. So that's all from me, but I'm happy to take questions.
Thank you. Do we have any questions? Are we going to take live questions? If not, do they just go through the written interface? No? Well, one thing I'd like to share, first of all, is the CLE code. It is EWMZO. If attendees have questions, we can answer them. I know we have a few already. So one example of one question that we received from the audience that I'll relay probably to Leanne is for audio-video telehealth for real-time synchronous video. Is the audio-video part of the designated record set if there is a written interpretation or findings that are sort of separately included? Maybe, Leanne, you could touch on that.
Okay, so in general, a covered entity has the ability to define its designated record sets, and the scope of the designated record set includes information that's used to make treatment decisions. The designated record set is not always the same as the medical record that is subject to record retention requirements under state law. So I would say in general, for example, if information about the nature of the consult, the treatment, etc., is included in, for example, an individual's electronic health record, and that's identified as the designated record set, that would be the information to which an individual has access under HIPAA. However, an entity may still need to maintain the audiovisual component under the medical record requirements under state law.
Thank you. I have just got a slew of questions asking me to repeat the CLE code, which is very important. It is 5 letters. E as in Edward, W as in witch, M as in mozzarella, Z as in zebra, O as in Oliver. EWMZO. I'd also like to note that for anyone else interested in terms of tools or checklists, we have those available as well that are just available as an educational module, the telehealth compliance checklists, as well as business associate security readiness to-do list and checklists. They're useful tools for providers who want to self-implement their own privacy and security or protocols, or do their own self-executed risk assessments for their telehealth program. So if you want one of those, just reach out, and those are available to anyone who's listening in on the call. Similarly, a little plug for healthcarelawtoday.com, which is our blog. There's probably about 50 articles on telehealth, including a whole number of discussions on privacy and security. You can see all of those, and they address specific legal business issues regarding telehealth, privacy, and security. Again, one more time on that code, EWMZO. And at this time, I would like to extend significant thank you to Brandon Welch, Michael Carter, and Leanne Habte for your time and sharing your educational information. And thank you for all the people who have attended this webinar.
Thank you, Nate. And I would also just like to let attendees know that Foley is co-hosting with the Personalized Medicine Coalition, AmerisourceBergen, and the California Life Sciences Association a one-day Personalized Medicine Summit in San Francisco on October 7th. It will be a one-of-a-kind thought leadership and networking forum, and it features an agenda focused on critical business questions, issues, and opportunities regarding funding, research and development, public policy and regulation, and technology, and more. So there will be fresh discussions with key opinion leaders and each other, and attendees should collect insights and arrive at solutions that will drive their individual growth and performance. Entities that have attended this Foley web conference will receive a 40% discount. The VIP rate is $175 off the regular $295 rate, and the discount code is Foley VIP15. So if you are looking for more information on the summit or to register, please visit personalizedmedicinesummit.com. Thank you.